Polymyalgia Rheumatica, or PMR, is a relatively common inflammatory autoimmune condition characterized by bilateral aching and stiffness of the shoulders and hips. It's a really important disease because it's easily treatable, but has serious complications like giant cell arteritis. At the end, I've got a great mnemonic. I use CPR, ABC to help me remember key diagnostic features and management. Let's start off with its signs and symptoms. You should think about PMR's clinical features in terms of systemic and musculoskeletal problems. Systemically, fever, weight loss, fatigue, and malaise are common. However, the musculoskeletal symptoms like shoulder girdle pain and hip girdle pain are the hallmarks of PMR. This is most noticeable in the morning for around an hour. Moreover, pronounced stiffness is particularly common with patients finding great difficulty turning over in bed, rising from a chair, or lifting their arms above shoulder height. Now, this stiffness also tends to improve after hot showers and with activity. Risk factors are important to know because polymyalgia rheumatica occurs almost exclusively in people older than 50 years old. Its incidence actually increases with age and is more common in females. Additionally, about 15% of patients with PMR also have giant cell arteritis. Formerly known as temporal arteritis, this complication is a vasculitis that typically affects the ophthalmic artery and can cause blindness. Jaw claudication, severe headache, visual symptoms, and scalp tenderness are the classic signs of GCA. Jaw claudication in particular is almost pathognomonic. GCA is an emergency and it should be treated immediately. Assessment of PMR is actually very difficult because there's no definitive investigations for it. However, you should always perform an erythrocyte sedimentation rate and/or a C-reactive protein. These are very sensitive but not very specific for PMR, meaning a diagnosis is unlikely if the ESR is normal. Interestingly, steroid response is a good diagnostic indicator of polymyalgia rheumatica. You should reconsider the diagnosis if steroids fail to achieve a rapid symptomatic relief and a rapid decrease in inflammatory markers. There are a number of mimics for PMR that you should be aware of. For example, fibromyalgia, rheumatic arthritis, myalgias due to drugs like statins, and rotator cuff disease are commonly mistaken for PMR and must be excluded. Now, if the patient actually does have giant cell arteritis, don't wait for definitive testing. Start management early. However, it should be investigated afterwards. If available, rapid access vascular ultrasonography of the temporal and axillary artery is the first line to diagnose suspected GCA, and it can show wall thickening called the halo sign. If this isn't available, a temporal artery biopsy is a specific test for GCA, but it has to be performed by a surgeon with experience in this procedure. As inflammatory infiltrates may be focal and segmental, skip lesions might occur, which means multiple sections of the artery might be examined. When thinking about the management of PMR, consider non-pharmacological interventions, pharmacological treatment, and complication management. Lifestyle optimization is key and includes encouraging patients to take gentle exercises, eating a balanced diet, and smoking cessation. Pharmacologically, a long course of corticosteroids is required to successfully treat PMR, and even with appropriate dosing, relapse is very common. Treatment is usually required for at least 12 months or more, and early or quick tapering regimes significantly increase the risk of relapse, which might need even higher doses and even slower tapering. It's important to remember that long-term corticosteroid therapy can cause significant adverse side effects, like reducing bone mineral density, which increases fracture risk. In specific circumstances, methotrexate is added for its corticosteroid-sparing effect. The main complication of PMR, other than glucocorticoid-related adverse effects, is giant cell arteritis. It requires specialist management with immediate high steroid doses. Patients with evolving visual loss require initial treatment with IV methylprednisolone. In patients that do not have evolving visual loss, oral prednisolone is usually required. To prevent ischemic events, including ophthalmic vascular thrombosis, use aspirin concurrently with corticosteroid therapy. To remember the presenting features of PMR and giant cell arteritis, I like to think of it as a potential emergency. PMR presents with CPR, and you should assess for GCA with ABC. CPR stands for raised C-reactive protein, pain in the hip and shoulders, and an immediate and rapid response to steroids. Giant cell arteritis should always be screened for by asking about aching head, blindness, and claudication of the jaw. Thank you so much for watching Townsend Teachings. Don't forget to like, comment, and subscribe. It really helps the channel.